This lecture will be on shortness of breath. This is part of the Intern survival series. The outline of my talk will include definitions, followed by etiology, and finally our approach. It will mirror somewhat of a SOAP format. Beginning with the definitions, first we have another word for shortness of breath, a medical word, dyspnea, which just simply means difficulty breathing in short. Dyspnea can be categorized as acute, subacute, or chronic. Acute being hours to days, depending on the condition. Chronic being greater than 4 to 8 weeks. Finally, acute on chronic can be a combination. We have respiratory failure, which is simply decreased oxygenation or increased CO2. Finally, our other terms include hypoxemia, which is oxygen deficiency in arterial blood. Hypoxia is oxygen deficiency in tissues, and hypercapnia is high CO2 in the blood. The reason our definitions are important is because this can not only affect billing and coding, as you can see on the screen here. So a picture of EPIC. You can see chronic respiratory failure versus acute respiratory failure versus acute hypoxic respiratory failure, etc. Not only coding, billing, but also in our presentations as an intern, you can sound better by saying acute on chronic hypoxic respiratory failure rather than problems breathing, or you could say something like mild intermittent asthma with acute exacerbation. Not only sounds smarter, but it adds more. It tells more to the story of what's going on, being as specific as possible in your assessment. Etiologies of shortness of breath include all of the following on the screen. I put the ones in red that in my clinical experience you see more commonly. These include pneumonia, COPD, asthma, PE, pulmonary embolism, heart failure, anemia. So you should have a working schema for at least all the ones in red, and you'll build on these ones in black as you continue your training. Talking about etiologies, one way you can think through shortness of breath are 6 different etiologies. So we have hypoxemia, oxygen deficiency in the blood. The 6 different etiologies is previously talked about, but we'll go over each one. So you can have low inspired O2 content, which is rare to see. You might see these in high altitude settings. So you probably won't encounter that unless someone literally just came back from some kind of trip. Usually self-corrects pretty quickly. Next you have alveolar hypotension, so breathing too slow or too shallow. This is seen in neuromuscular disorders, like if you had a myasthenia gravis crisis, perhaps obesity, if someone had too much opioids, maybe trauma, like especially to the brain, could kick in a reflex. So this is kind of rare too. Next would be low mixed venous O2, so too much blood returning to the right heart that have lost too much oxygen. So blood returning to the heart that's just given up all its oxygen to the tissues. So you'll see this in shock often. That's where you're talking about low mixed venous O2. But it's just a rather more common cause. The next is a VQ mismatch, which is I put as the most common cause. That's something that you see in many of your diseases. You see in heart failure, you'll see in COPD exacerbations. Basically, the amount of ventilation per the amount of blood flow. More blood will be going by than this getting oxygenated. So that's why you'll see that in a COPD exacerbation where the oxygen going into the lungs is not enough for the amount of blood flow going by, and deoxygenated blood goes by, and they're having clinically significant hypoxemia from that, not oxygenated blood. The next is right to left shunt. So this is probably another more uncommon cause where you see this in congenital pediatrics probably with a right to left shunt. You may see this in later like Eisenmenger syndrome or with severe valvulopathy. So somehow blood from the right heart going to the left heart without oxygenation happening. think you can think through a number of reasons that would happen physiologically and pathologically. So the last is diffusion limitation, which is impaired alveolar interface. Um, so of course, with that, most noticeable with activity, but yeah, any pathology to that capillary alveolar interface that may thicken it or cause some kind of breakdown. Could cause hypoxemia, such as if you had fluid in there, if you had blood in there, if you had some kind of interstitial process that was thickening the layer, making it hard for oxygen to pass through. Then finally, again, emphasize hypoxemia and hypoxia are different. So hypoxia is actually what's going on at the cellular level. Usually these two always correlate. Whatever you breathe in, your tissues are getting. Whatever you don't breathe in, your tissues aren't getting. There are cases where this doesn't happen. This is somewhat more relevant for boards, but does happen. You'll probably see a couple cases throughout your training at least. So you have hypoxia without hypoxemia. So basically the pulse ox will be normal, right? But your tissues are not receiving oxygen. So the way you kind of suspect this clinically is those anion gap metabolic acidosis, such as if like your patient's lactate continues to rise, or they have a super high lactate, but you put the pulse ox on them and they're normal, they seem to be breathing fine. Or just like suspicious history, like maybe they're mixing some kind of chemicals or drinking some kind of weird substance. They recently moved somewhere or were on some kind of vacation, especially if they're in like a cabin up north. This is where you think of these carbon monoxide poisoning, cyanide, methemoglobinemia, like nitrates. Maybe they were fertilizing or doing something with their lawn. Yeah, just kind of more uncommon causes, but certainly you wouldn't want to miss a rising lactate and have no explanation. That could be very serious. So it's just another way to think through. So we'll keep going to our approach, kind of in our assessment. So whether this is clinic or floors, I kind of put different situations you might find yourself in. You'll notice that in all of these, my first step, no matter whether it's with a new patient, with an established patient, clinic or floors, or in a wrap, your first step is always going to be triage. How are they doing clinically? It's a shortness of breath. Shortness of breath is almost always some kind of immediate issue that you need to respond to. Perhaps in clinic, not so fast, but it's just one of those calls that can be serious. Kind of like chest pain. It could be something awful that you don't want to miss and then you need to respond to right away. So triage is always the first most important thing. How do they look clinically? How are they doing? Do you need to throw oxygen on them? Do you need to like stat order some kind of medication to help them out? Do you need to get them to the ICU immediately? So with new patients, it's just gathering your HPI as normal. Your OPQRST is one way to think about it. What are the history, the present illness. The past medical history can really key you in. If they have known COPD, if they've had pulmonary function test 5 years ago that showed moderate COPD, you can suspect that their disease only advanced, and for instance, so your pretest probability of that is higher. What are their vitals? Elevated heart rate, you think pulmonary embolism. Are they actually deoxygenating? Do you examine them? Do you see clubbing? What do you hear in their lungs? Do you notice abnormal heart sounds? Do they look pale? These are all kind of cues. And then you got your studies. So established patients kind of similar, but really the question is like what changed or what other symptoms you have. And assuming they weren't shortness of breath just sitting there in their hospital bed, what could have happened? Almost always, or pretty much, I'm just going to say always see the patient at your level of training. And then once you see the patient, chart review, see if there's anything in the nursing notes or anything happened. Look at their vital trends, if their heart rate's slowly been going up. Are they AFib, RVR now? That's slowly elevated, or did they get like an arrhythmic change that you could, you need to order that EKG. And then, what studies do you need? Chest X-ray, EKGs are very easy studies, tallies, getting labs, basic labs, and then VBG or ABG, very low risk, high yield. So other pearls that I always want to say is pretty much always, if you don't have an immediate obvious explanation, um, such as like they're obviously like pulmonary embolism or something, like haven't been on heparin. Pretty much always look through their meds, see if they've been getting a lot of opioids lately. This is commonly missed and commonly seen. And then another one is kind of mental status and swallowing function. So um, one thing to think about when they're having trouble breathing is if they've been, do they have some kind of condition that causes trouble swallowing and maybe they aspirated? Or is their mental status depressed and they had some kind of aspiration? Often we don't think about aspiration immediately, but certainly always a good thought to throw out there pretty much in any situation. Then finally for reps, we have triage, so immediately what do they need? Stabilize them immediately, and then diagnose. All these ideally comes as fast as possible, but you need to treat your patient first. It's hard to treat something if you don't know what the diagnosis is, so try to use those high yield tests that you'll learn over time. Again, like valuable ones is look at the tele, look at the EKG, look at the chest x-ray, look at your basic labs that you might have ordered. So our approach, these are some of the history elements, some things that you can just think about asking, to think about what's going on. For example, if they've had syncope, now you're thinking like maybe some kind of cardiac arrhythmia going on that could be related. If they have edema, that increases your test probability for heart failure. Versus like fevers, chills, now you're kind of thinking like pneumonia. Each one of these should be purposeful and lead to some specific diagnosis, ideally. When you're thinking about your approach and gathering your history elements, over time you'll start building this up. Hopefully towards the end of your intern year you'll get decent at this. But to increase your sensitivity for like heart failure, you can kind of think through or ask questions based on or present based on like Framingham's criteria. You can say they have orthopnea, you can say they have edema, shortness of breath, and all this builds up. All these are just sensitive items to catch heart failure. For example. So there's different criteria for many diseases. Another one would be like pneumonia. This, I guess, like curve 65 would be like pneumonia severity. This is kind of in clinic. You're thinking if they need to go to the hospital. Maybe another thing is like as you learn symptoms, you'll know like the most sensitive symptom for pneumonia is actually cough. So they don't have cough, and maybe you think it's not pneumonia, but of course it's not near 100%. But it's just like things that you can build up your clues to clinical suspicion. That's why I put caution on the H&P alone. Like orthopnea is very specific for heart failure, but doesn't mean heart failure. Nothing's really 100%. It's just building that suspicion. And then finally, your specificity. That's your ordered differential. Being better at doing that and building up your clues will help with your specificity of knowing this is the diagnosis. Kind of one example I put too of another situation with specificity is tests often help with that, getting those PFTs if it's in clinic. I think it's underutilized for asthma. We had a case of asthma, which we thought for sure was slam dunk asthma, started treating it, obtained PFTs rightfully, but it was actually Wegener's that is hard to suss out with history, but that testing really kind of told us. So, and that's critical to miss. You have a totally different treatment course. So, next we have our exam features. Some of these will cue us in on certain ones. So if you see JVD, distant heart sounds, you're thinking heart failure, clubbing, you're thinking maybe like interstitial lung diseases, urticaria, you're thinking allergic processes, and then you have like tachycardia, you're thinking like AFib RVR or arrhythmia, or you're thinking pulmonary embolism, wheezing, that's pretty good slam dunk, that's probably an asthma or COPD, but heart failure could be that. But all these kind of again cue you in and build up those clues so that you intelligently present a good assessment. And then this is just kind of exam features, so make sure that you know your exam features. Don't be afraid to get your mini evaluations and have attendings like double check your exams. There's a lot of debate about exams nowadays and provider interdiscrepancy, and how specific it is, but it's if you're good at this, and especially in low resource areas, this is only helpful, I would argue. The other thing I put here is a YouTube link. I'll let y'all look this up because things can change, but just knowing your different lung sounds. What does a crackle sound like? What does a wheeze sound like? What does stridor sound like? Um, and knowing what these are. So crackles are rails. Some attendings won't know that. Yeah, this will all help you. So make sure you do that or know your hard sounds, lung sounds. So testing, this is again going back, I guess, to somewhat to triage, but back a little bit to other approaches and how you go about doing things. So you have the chest X-ray, EKG, VBG, and lactate. These are things I mentioned that pretty much always are right. You can hardly argue it's not right to get. Other specific testing in certain scenarios, if this is inpatient acute, CAT scan, you can't really do that acutely. You can do it somewhat acutely, but more subacute or not immediately at bedside if there's like a wrap. But CBC, BMP, very often you'll get those, but if you've had a recent one, may not be helpful. Troponin, I wouldn't just get those because you have to interpret that, how to make sure it clinically correlates. But these are different tests you can get nonetheless. Kind of ramble in here. So, acid-base assessment. So know how to interpret ABGs and VBGs in short. I put some tips here. So on an ABG, 60 milligrams of mercury corresponds to a 90% saturation. So you can kind of use that as a baseline to tell you if it's roughly more or less than that. So it's a good number to memorize. VBGs give CO2 and pH reliably, not O2, right? Because it's venous and the oxygen's gone. So never report your oxygen. You'll probably do this a few times in your intern year, but never report your oxygen on a VBG. So there's kind of some tips here about like the pH, how it will lower every however many CO2s. It's something that you'll kind of build on your knowledge base, and then BMP also will give your bicarb, and it's a really good way to check that. So that's really good to report. These are especially in the ICU. And then finally, the last thing is know your X-rays. I thought this was actually a really comprehensive and good picture of all the different X-rays that's possible. Yeah, all these correspond to a certain disease process, so I wouldn't just kind of ignore these. So what are you going to do? This is essentially what plan are you going to deliver? Based on everything that you gathered and everything we went through, you should have a pretty strong assessment or idea of what's going on. The plan kind of writes itself often. This is different in different situations. I put oxygen in red because in a wrap, when you're triaging someone, it's very easy and not wrong and easily forgot to do oxygen. Just put them on oxygen, put them on something. There's different delivery devices here. Basically, all I separated it. These are all like non-pressure support ventilation. They provide oxygen, but they don't provide pressure, so they would help your oxygen, but not your CO2 as much. So any one of these can work. It's really whatever the patient tolerates and what they need. And then you have your non-invasive pressure ventilation, so you have the CPAP and BiPAP. Often this means that they're being transferred from the floors to like the ICU, whether it's a step down or true ICU. The rate of progression and instability will determine that, and kind of go through some of those situations in other videos. And then you have your invasive oxygenation. You have your trach, which hopefully not doing, especially in IM. Especially in controlled environments, or you have your ET tube, endotracheal tube. Other treatments that you can start, immediately if someone has acute shortness of breath or they're coming in with shortness of breath, you can start them on antibiotics, appropriate CAP coverage, or appropriate HAP coverage, or whatever that may be. There's something else going on. Lasix is easy to immediately give. The onset is less than an hour if you do IV Lasix, but Not immediate, but it's still something you can do. You can put them on heparin if you think pulmonary embolism. Certainly, don't let that pulmonary embolism worsen. Duonebs and steroids. These are treatments for asthma, COPD exacerbations. If they're anemic, you find you can give them transfusions. You can order thoracentesis or chest tube. Whether it's like a procedure consult or pulmonology consult. Um, these might be needed ultimately if the suffusion's too large. You can't do whatever you need for your patient. And then finally, the last two are, call the MICU, let the fellow or the team know something's going on. Call a RAP if you need. Call a code if you need. As an intern, it's better to be safe than sorry, I would say, especially early on. People will be more forgiving, and you don't want your patient crumping. As long as you're communicating out loud with everyone, you'll get through it. I feel the worst thing to do is just not communicate, or just be silent. Just talk it through. The nurses are often decently skilled, and they have seen these happen, and they have somewhat of an idea of going on. So talk with them and talk with the RAP team if you have one at your hospital. So yeah, in summary, history exam differential. Go through the basics. Go through your subjective, objective. Then next, stabilize, and then get your tests to make sure you're diagnosing and treating the right thing empirically. Your working diagnosis. You can always take things off. It's unfortunate someone gets a dose of anticoagulation, heparin, or antibiotic, and they don't need it, but this is part of your training, and as long as you're talking things through, usually mistakes won't happen. So just keeping communication. With critical patients, always do something, I would say. Whether it's just putting on oxygen and reaching out to your senior ICU or hitting the code button, or actually like going through it and figuring out what the answer is, as you get more comfortable. I would reassess pretty much always, especially early on when you're figuring things out. I would do it within the hour or sooner. And then again, if stabilizing or unstabilizing, unstable, or worsening, call ICU. Consider if they need intubation. That's really the main question when you're calling ICU. So if you have any questions, feel free to comment them. Know your ICU attendings number and who's on call and all that every day that you will be in a situation where it could potentially be rapid. Thank you.